Welcome to the scientific section 9 on the calcium and bone metabolism. And this is held in collaboration with Southeast Asian Federation of Endocrine Society. I am Dr. Mujib Rahman Abdo. I am currently working as assistant professor and head of Department of Diabetes and Endocrine, SMBB Medical University, Larkana. I will be honored to be moderate this session today. Before starting the sessions, I would like to call the chairpersons to please come on the take these chairs on the stage. So first of all, I will invite Dr. Neil Somasundaram from Sri Lanka. He is the consultant endocrinologist and Diabetes Endocrine Center, Colombia. He is currently a president of South Asian Federation of Endocrine Society. Thank you, sir. So our second chairperson is the Dr. Amina Mozam. She is the consultant endocrinologist and serving in the Services Institute of Medical Science in Lahore. So our third chairperson is Dr. Hafiza Nas from Pakistan, and she is assistant professor of endocrinology and head of Department of Endocrine Section. This is, please, madam. So we have two talks today. First, I would like to call Dr. Uneeba Syed to please come on stage and have a talk on management of hypoparathyroidism in pregnancy. Dr. Uneeba Syed.
Thank you so very much for the kind introduction. So basically, this lecture was supposed to be delivered by our international guest, Dr. Wali. However, due to visa issues, he could not make it, and I was given this task, to Gigi. I can do it. So I'll just get through my presentation. So hypothyroidism in pregnancy. Let me tell you first that hypothyroidism in pregnancy is not very common, and it's not something on which you can find a lot of literature on. And ये है pointer? Okay. So parathyroid gland, we must all be well aware of. These are the ovoid bodies which are almost 6 millimeters long, are 4 in numbers, lying within the facial capsule. And they are located on the posterior and medial aspect of each lobe of thyroid, on the back side here. And they produce the hormone, which is a parathyroid hormone. So the thing that I need you to understand is what parathyroid hormone does. Because if you know what it does, you will actually know that when it is not there, what happens. So this is how it looks like when calcium metabolism is concerned. So this is when the calcium concentration in the blood, it drops. So what happens is the chief cell of the parathyroid gland here, they release parathyroid hormone. Now this parathyroid hormone, it has different ways of functioning. Now look at this, the effect on the bones. This is the osteoblast, which is actually, here. This is osteoclast, which is eating away the bone, and you can see the calcium going out into the blood. This is what parathyroid hormone does. It inhibits the osteoblast, which is actually laying down the bone. It stimulates the osteoclast indirectly, and the bone is broken down, releasing the calcium into the bloodstream. Okay. Then the effect on the kidney. Now what happens is that in the kidney, in the urine, almost 250 millimole of calcium is excreted per day. And out of that, 245 is reabsorbed when the PTH, it stimulates the kidney tubule cells and recover the waste calcium from the urine, which is almost 245, I just said. It also stimulates the kidney tubule cells to release calcitriol. So on kidney, there are basically 3 functions. Number 1 function is, I have told you, the calcium one. The other one is that it inhibits the reabsorption of phosphate, so phosphaturic is there. And number 3rd is it causes the release of calcitriol. So basically it stimulates 1-alpha hydroxylase, which converts 25 hydroxylase into the 125 hydroxylase. So because of this, what happens is there is effect on intestines, and so this is the intestinal cell, this is the calcium in the food, so it stimulates the intestine to absorb the calcium from the digesting food. And through all these mechanisms, what it does is it increases the blood calcium level that was initially dropped. Now this calcium level is there, so what happens is The high concentration of calcium, it stimulates parafollicular C cells in the thyroid to release calcitonin. अब calcitonin क्या कर रहा है? इसके opposite काम कर रहा है. This is the osteoblast, वही bone lay down कर रहा है, वही osteoclast eating away the bone. But calcitonin now what it does is it stimulates the osteoblast. इसके लिए stimulation हो गई, इसके लिए inhibition हो गई, and calcium is removed from the blood into the bone. So this is how the homeostasis of the calcium is actually maintained, right? Moving forward. Let's see what is the impact of pregnancy. This is the pregnancy with no hypoparathyroidism. So we know that calcium is tightly regulated, and all, you know, in pregnancy what happens is the calcium metabolism has this order from Allah Pak that fetus ki bones banni hai, so calcium and mineralization has to go there. So you can see that almost 50% of the calcium is bound to albumin, 40% it is free ionized calcium, and 10% is complex to anions. Now during pregnancy there is active transfer of maternal calcium to the fetus, right? And a full-term infant requires almost 25 to 30 gram of calcium during the pregnancy for the bone mineralization, and the total calcium in the gestation, it is actually 8% lower than that in the postpartum. Sorry, now here. Look at this, these are the changes in pregnancy. So calcium ko kya ho raha hai? So during pregnancy, all of us know that serum albumin decreases because the intravascular volume has increased. So what happens is, if you look at the total calcium, it will decrease. However, the ionized calcium, or if you calculate the corrected albumin corrected calcium, it is normal here. So, and the phosphorus, it remains unchanged. Then parathyroid hormone. So parathyroid hormones is suppressed, and it may actually decline below the reference range in the first trimester, but subsequently it rises into the mid-normal reference range, and it is also affected by the maternal dietary calcium as well. अब जो मैं नाम बोलती जा रही हूँ, जो मेरी first slide थी, उससे आप relate कर सकते हो. Now we are to the calcitriol. So what happens? It rises in the first trimester and increases by 2 to 3 fold by the term. And why this is increased? Because it increases the calcium absorption and suppresses parathyroid hormone. So basically the increase for the calcitriol, the basic source is the kidneys, and the other source is placenta as well. So pregnancy is associated with increased renal expression of cytochrome 27 beta 1, which it is almost 35 times higher in kidneys. So basically kidneys have major role to play with calcitriol. Coming to the calcitonin, serum calcitonin, it rises during pregnancy. And why it rises? Because it has to protect the maternal skeleton from demineralization during pregnancy. So it rises. And the source of calcitonin, it is thyroid C cell in addition to the breast and placenta. Parathyroid hormone related peptide. This is somehow, it has its importance here. So this begins to rise from the third to 13th week of gestation. It increases by 3 folds in comparison to the pre-pregnancy level. And this rise may upregulate the calcitriol and suppress PTH. So what happens is, PTH related peptide, it causes increased intestinal calcium and phosphate absorption. This I've already told you, which the point I'm trying to make here is that also causes increased urinary calcium. So this is also responsible for calciuria. In the lactation, what happens is, after the delivery, there is decrease in estradiol, and also there is parathyroid hormone related peptide released. So both of these, इनका काम क्या है कि they will cause the calcium resorption from the bones and to enrich the milk with calcium so the baby can take it. Now we come to the hypoparathyroidism in pregnancy, which I have told you it's a rare disorder. We have low calcium in the presence of low or inappropriately normal parathyroid hormone. The phosphorus may be normal or elevated. And why is it important? It is important because the endocardial skeleton of the embryos gradually mineralizes with approximately 80% of the mineral occurring in the third trimester. Now what happens is, even in the presence of inadequate maternal calcium, the fetal requirements are met. Fetal hypocalcemia only occurs when there is severe hypocalcemia in the mother. So in severe hypoparathyroidism with severe hypocalcemia, the fetus can develop hypocalcemia. अब उसको जब hypocalcemia हुआ, वहाँ से stimulation गई to parathyroid hormones of the fetus and they develop hyperparathyroidism, उसको compensate करने के लिए, which will in turn cause demineralization of the fetal skeleton, and sometimes if it is very severe, it can lead to all of this with subperiosteal bone resorption, bowing of long bones, osteitis, fibrosa cystica, and all of these which can be seen, and it can be as severe as possible fetal death. Now, coming to the etiology. So etiology is not that simple. Still, it's not that complex because we know that maximum number of the patient, almost like 75%, this is because of the post-surgical. So that is the most common. It is 75% of the cases of post-neck surgery. It can be due to anything. Thyroid में निकाल देते हैं surgeons for some reason, उनसे निकल जाता है parathyroid hormone and they are unable to say. It can be due to cancers, it can be due to goiter. पता कैसे चलेगा? You will ask the patient for the history. आपको पता होगा patient की surgery हुई है, you can see the scar, right? Then you have autoimmune disorder. It can be a part of an autoimmune syndrome like APS1, which have other features like जब आप देखेंगे या पूछेंगे history examination पे, you can have mucocutaneous candidiasis, adrenal insufficiency. So APS1 is there and it can be only isolated as well. Then you have genetic disorders. DeGeorge syndrome, Barakat syndrome, which have deafness, renal anomaly along with it. It can be autosomal dominant hypoparathyroidism, isolated, and even mitochondrial disorders like MELAS. They can also present with the genetic disorders. Radiation exposure. Any sort of radiation for maybe thyroid cancer, they can lead to hypoparathyroidism. Mineral deposition. Now this is important. So mineral deposition, maybe in the form of copper deposition like we see in Wilson's or hemochromatosis. What happens is that they are deposited in the parathyroid and parathyroid is destroyed. Infiltration. It is rare. Like not very common, although this whole thing is rare, but it is further rare. So granulomatous diseases, sarcoidosis, amyloidosis, or even metastasis, they infiltrate the parathyroid and they cause the hypoparathyroidism. This is very, very important. So magnesium deficiency के अंदर एक बात याद रखें कि what happens is they block CAMP in parathyroid and cause impaired parathyroid secretion. बस यहाँ तक भी याद रख लेना कि they causes impaired secretion of parathyroid hormone. मेरा काम हो गया. And then drugs, obviously, the chemotherapy, chemotherapeutic drugs. History में भी आपको मिल जाएंगे क्या chemotherapies. And how they act on parathyroid is they cause the necrosis of parathyroid, so thus causing hypoparathyroidism. इसके लिए करना क्या है? You have to investigate with the primary investigations like ionized calcium or the corrected calcium as we have discussed. Fasting intact parathyroid hormone, whenever you write it, you write fasting intact parathyroid hormone, phosphorus or magnesium with vitamin D renal function test. And after that, you have to look for all the other causes if you have the history and examination supporting that. For example, for APS, you can look for adrenal insufficiency, B12 deficiency, autoimmune hepatitis or other autoimmune conditions. You can look for any cardiac abnormalities or sensorineural deafness or growth retardation for genetic mutations. Even for example, if you find a case of fissure ring, you have to look for infiltrative disorders, or maybe a patient is of thalassemia and patient has a history of multiple transfusions, so you know there is a possibility of iron deposition, and you can see. And then for the granulomatous disease, sarcoidosis, just keep in mind that if history and examination supports that, you do these investigations. I'm almost near to the end of my presentation. Treatment. Just listen that, simple सी treatment simple सी है, लेकिन इसको maintain करना is very, very difficult. So basically it includes the serum, the calcium supplements and elemental calcium. It can be as much as 3 grams per day. So 1 gram TDS का मतलब है कि you can give it like 3 grams in a day, along with more potent analogs of vitamin D like calcitriol or alpha calcidor in the dosage of 0.5 to 2 microgram per day. Now the PTH is not approved in pregnancy. लेकिन इसमें इम्पॉर्टेंट बात क्या है? इसमें इम्पॉर्टेंट बात ये है कि केयरफुल मॉनिटरिंग ऑफ सीरम कैल्शियम इज़ रिक्वायर्ड विद द मेंटेनेंस ऑफ सीरम कैल्शियम इन द लो नॉर्मल रेंज। होता क्या है कि अगर हाइपोकैल्सीमिया हो जाएगा मैटरनल, तो वही बात हो जाएगी जो मैंने पहले की थी, फीटस के पास नेगेटिव फीडबैक जाएगा, उसका हाइपोपैराथायरॉयडिज्म हो जाएगा, जिसकी वजह से ऑल द डिफॉर्मिटीज़ दैट आई टोल्ड यू इनिशियली वो हो जाएंगी। अगर आप इसको ज़्यादा लोअर नॉर्मल नहीं रखेंगे, ज़्यादा कैल्शियम दे देंगे, तो क्या होगा? कैल्सीयूरिया होना शुरू हो जाएगा। जब मैटरनल कैल्सीयूरिया होना शुरू हो जाएगा तो वो नेफ्रोकैल्सिनोसिस एंड स्टोन फॉर्मेशन करेगा। सो दिस इज़ वेरी इंपॉर्टेंट टू अंडरस्टैंड कि यहाँ पे जो बैलेंस मेंटेन करना मुश्किल है, दैट इज़ यू हैव टू कीप द सीरम कैल्शियम इन द लो नॉर्मल रेफरेंस रेंज, उससे ज़्यादा भी नहीं, उससे कम भी नहीं। और इसकी जो मॉनिटरिंग है, यू मॉनिटर एवरी 3 to 4 वीक्स ड्यूरिंग प्रेगनेंसी। लेकिन फॉर एग्जाम्पल आफ्टर 3 to 4 वीक्स पेशेंट कम्स विद द रिपोर्ट इट इज़ नॉट एज यू वांटेड इट टू बी, सो उसमें क्या होता है कि यू मॉनिटर एवरी 1 to 2 वीक्स। एंड आई वाज जस्ट गोइंग थ्रू सम रिसेंट अपडेट्स एंड इट वाज जस्ट सेड दैट नियर द 3rd trimester और डिलीवरी यू कैन इंक्रीज द मॉनिटरिंग from 3 to 4 weeks per 3 to 4 weeks to 1 week or every 2 weeks as well. Along with this, you keep serum phosphate, magnesium, 25 hydroxyvitamin D and 24 hours unique calcium it maintained in the normal reference range. And this is it. This is all about my presentation for hypoparathyroidism in pregnancy. Thank you.